All right, we're going to talk a little bit about some craniofacial abnormalities and common pediatric syndromes. Both of these topics are pretty popular for board exams. So one of the things you have to understand is part of our growth and development of our skull. And what you see is a lot of these different fontanelles come together at these suture lines. And especially when we start talking about some of these syndromes, you'll see that that's where we really run into major problems is when those sutures don't form appropriately, they form too soon, too late, or have some sort of abnormal growth. So you can see as we go from 12 weeks gestation to newborn that these sutures start to form and our skull actually starts to kind of take the shape we're familiar with. As this happens, that's when we tend to see that things don't fuse appropriately. So this is some examples of different types of synostosis that you'll see. And as you can see here, what happens is when that suture line forms too early, you wind up with abnormal growth and development opposing that. So for instance, the unilateral coronal synostosis, you've got abnormal growth on the right side. Lambdoid synostosis, you have growth on the posterior right. Sagittal synostosis, you kind of have more of a football shape. And the metopic synostosis, you have more of a cone head, but as opposed to being a cone head as we think of from the movie, this is more of an anterior presentation. This is an example of what you see with the sagittal synostosis. They tend to have a little bit of elongated head. Metopic, they tend to have a little bit more of a pointy forehead that you can see there in kind of that bottom left picture. The good news is most of these are pretty easily treated, especially if they're caught early. A lot of times it's done through conservative therapy with just skull shaping helmets, but sometimes they do require surgical correction. And these are just a variety of examples for you. As with the others, all these lectures tend to have some examples for you because I think visual recognition is one of the most important things we do for these patients. So when we start talking about craniosynostosis, it's a congenital abnormality, like I said, where one or more of the cranial sutures close before they're supposed to. Incidence is fairly uncommon, 1 in 3,000. Males are more often affected than females. In about 80% of these cases, they are isolated, while 20% you have a combination. And the important thing to recognize here is not only do you tend to have the skull abnormalities, but you also have about 400 different syndromes that may associate with that. Apert syndrome is one of those syndromes. Incidence is approximately 1 in 100,000. And what you see here is that they have kind of a clover leaf skull craniosynostosis. Additionally, they tend to have syndactyly, mid-face hypoplasia, proptosis, and hypertelorism. And we're going to talk a little bit about those as we kind of work through things. So this is an example of kind of a visual recognition pattern for those patients. So what you see is kind of a combination of things here. Malformation of the skull, the face, the hands, and the feet. It's one of the branchial arch syndromes that we talk about, which is basically the branchial arch is kind of the predecessor for the maxilla and the mandible. And we'll talk about a couple of those others as well here in just a minute. So you have abnormal fusion of the coronal sutures. As a result of that, you kind of get funny or enlarged skull, especially when we kind of think of a forehead. These are examples of the abnormalities you may see in the hands and feet. Oftentimes, these are surgically corrected, and part of that just depends on where the patient has the fusion. It may just be a soft tissue webbing, it may be everything altogether. So sometimes it's a little bit more difficult to correct. Next, we're going to talk about Crouzon syndrome. This is a pretty popular one for boards, as is Pierre-Robin and Goldenhar. Crouzon is similar to Apert, except that you have kind of some different ophthalmic defects. So craniosynostosis, proptosis, and mid-face hypoplasia. A decent number of these patients, about a quarter, have optic atrophy. One of the big differences is you don't have any deformities of the hands or feet here. So it's more of just the facial deformities here. Examples of what these patients look like, again, for that kind of visual memory. Another branchial arch syndrome. You tend to have that same large forehead, but a lot of times here you're going to have more optic deformities, which make it a little bit easier to differentiate. One thing I would encourage you when you have any of these syndromes is to ask the parents but also Google is your friend for a lot of these resources because it's very difficult to remember all the components for each of these syndromes, even if you work at a pediatric specific facility. Again, examples of the exophthalmos, the large forehead. Another picture for you. So when do we do surgery for these patients? One of the biggest examples you see is when they have elevated ICP, oftentimes due to cranial or skull restriction. Other things that they'll do it for: severe ophthalmos, obstructive sleep apnea, severe craniofacial disorder, which oftentimes leads to the next component of psychosocial disorders. So if it gets to the point where it's taking a mental toll on the patient, oftentimes they'll go ahead and opt for surgery. It also depends on the severity of the case. So things to think about from an anesthesia standpoint, big focus on airway management. A lot of these patients we're going to talk about today are difficult airways. So anticipate not only being a difficult intubation, but also very difficult to ventilate. These surgical cases tend to take quite a long time, so consider an arterial line for these patients or some sort of non-invasive continuous cardiac output or beat-to-beat monitoring. Be very cautious with the eyes, especially if they're operating very close to them, which they usually are because they're doing skull correction or OMFS type corrections of the mandible and maxilla. If they already have existing elevated ICP, be very cautious because they are at an increased risk. They do tend to be very vascular structures, so go ahead and get a type and cross done and perhaps have a couple units available. For these patients, it's fairly common to go ahead and either have some blood prepared through personal donation or cell saver. TXA is fairly common now for these cases, as are Foley catheters. They tend to take quite a while. For the most part, hypothermia is not the biggest concern because the only thing that's exposed is the face and head. So it's a little bit different than like you were doing a scoliosis repair or something like that. Depending on where they're working, like this is a patient for an encephalocele, you may have quite a bit exposed initially, but as you can tell here, they've got leads on the back. They're going to be able to cover all that up with drapes. So we're going to talk a little bit about some of these patients with Goldenhar. Again, visual recognition is kind of helpful for these patients. So when you look here, they don't tend to have that same enlarged forehead, but they do tend to have a lot of the same facial features, except for the exophthalmos. So a lot of these tend to go into the same classification, and we use what's called omens to go through and identify them. So this is pretty common. It's the second most common facial defect after cleft lip, cleft palate. And this is a result of the first and second branchial arches. So we use omens to classify it. So orbital distortion, mandibular hypoplasia, ear abnormality, nerve involvement, and soft tissue deficiency. So this is just an example of all those omens, but the big thing to take away from this is because of that midfacial hypoplasia, you may have asymmetry of the mouth and retrognathic mandible. They can be very difficult to intubate. So if you hop back and look at some of these pictures here, you're not really surprised when you look at some of these patients and figure out that they are difficult. That recessed jaw, the pronounced overbite, as well as just the small mouth opening kind of makes you worry a little bit about it. The good news is most of these patients are well known to the system. Very rarely are these emergent cases to have these things repaired. So you want to make sure that you do have airway supplies available, including your difficult airway cart. There is also a high likelihood with multiple surgeries that they may require pulmonary support, including tracheostomy, as you can see on the bottom right. So Goldenhar is the most common form we see. About 40% of these patients will have vertebral abnormalities, and about 35% will have congenital heart disease. So increased risk patients. These patients tend to have bilateral mandibular hypoplasia. As a result of that, they're predisposed to obstructive sleep apnea and a difficult airway. There's a lot of things you can take away from this picture on the right. You see the retrognathic jaw, as well as the deformities to the ear and the face. These are just some other examples for you when you look here, and you can see from the varying positions how recessed that jaw is, how the mandible is a little bit offset. So in this case, you may not have bilateral hypoplasia, you may just have one-sided hypoplasia. So again, making things a little more challenging for you. Another picture for you. So we're going to move on from that to Treacher-Collins syndrome, uh, characterized by a lot of the same things. And when you go through and study these, what I would do is go through and think about the things that are different, not the things that are identical, because that kind of helps you differentiate these. So again, mandibular hypoplasia, they may have microstomia. There's an increased incidence of cleft palate in these patients. They may have colobomas of the eyes. So you'll see like notched lower eyelids, sloping palpebral fissures, hypoplastic zygomatic arches, microtia, chondrocresia, CV defects, and renal defects. The picture on the right gives you a little bit of an idea for those patients as well. Um, it's probably not politically correct, but the easy way for me to remember this is that when I look at the nose and I think about how it curves around with the face, it kind of looks like a C to me. So the C for Collins, for some reason, always made sense to me. This is an example of the lower lid colobomas that I was talking about. You can kind of see the notching there. So this is kind of an inspirational story if you want to see kind of the long-lasting effects as well as the successful outcomes from somebody with Treacher Collins. There was a movie made. You can go back and see Wonder with Julia Collins or Julia Roberts, excuse me, and see kind of the life story of somebody with Treacher Collins. So these are almost all difficult airway patients. I would have a very low threshold for pulling the difficult airway trigger and anticipating that you need some help. Even in facilities where you deal with kind of a lot of these special needs kids on a regular basis, these are particularly challenging patients. So I would be pretty quick to go ahead and find all my friends, all my toys, and be ready for them. As far as anesthetic considerations for these patients, they tend to obstruct very easily because of the retrognathic jaw. They tend to have kind of redundant tissue that can be difficult, as well as just abnormal pathology in their airways. So anticipate them obstructing during induction as well as emergence. Oral airways may be beneficial, nasal airways may be beneficial, but because of their structural changes, they may not work quite as well as you would anticipate them working. Definitely make sure you've got the difficult airway cart in there and ready. I would probably go ahead and have the glide scope as well as a fiber optic scope ready to go. You may not need them at all, but it's a lot better to have it and not need it than be trying to find it. You can do inhalational or IV induction on these patients. Just anticipate that you may have a little bit more trouble if you do an inhalational induction because their airway may collapse on you a little bit. So just be mindful of that. Patients with Treacher Collins, their airway tends to get more difficult over time. So be cautious. Most of our patients, their airway does not get more difficult as time goes on. That's kind of one of the exceptions. For these patients, you can almost always use an LMA as a backup, and you may actually use that to introduce your endotracheal tube. This is an example of a patient with Pierre-Robin. It's a triad of micrognathia, glossotosis, and respiratory distress very early on in life. Most of these other disorders are a little bit slower to cause problems. Pierre-Robin's kind of the exception to that. And you can kind of see here from the side how difficult that can be. For patients with Pierre-Robin, as well as a lot of these others, I would consider putting an LMA in and then doing a fiber optic intubation through it. There's nothing wrong with that at all. Other things that you can consider for these patients, utilization of a tongue suture to kind of hold the tongue up out of place. And it's common for that to stay in place for quite a while after the procedure. It's not something that's necessarily just done for the case. Other things you may see with these patients because of their disease process, they may have difficulty flexing and extending their cervical spine. So you may have to intubate them at almost a neutral position. As you can imagine, that makes it a little bit more difficult for somebody that's already obstructing. And then they may also have cleft lip or palate. This is an example of that tongue suture, and this basically has a sterile button tied to it. And all they're doing is pulling this tongue up out of the airway, so that's not what's obstructing the patient. It seems very cruel, but it's not nearly as painful as it seems like it would be. We utilize tongue sutures for lots of different procedures, everything from tracheal reconstruction to OMFS cases to neurosurgery cases. So, kind of a common procedure. Other things you'll see, we talked about kind of the top three there, but you will also notice that some of these patients have congenital heart disease, um, the difficult airway that may be improving with age, and respiratory obstruction that can be severe. I think I said before that it's getting more difficult with age. I meant that it's improving with age. Just another picture for you. The thing I really wanted you to take away from this picture is that this is somebody that's actually having their jaw advanced. So if you look down there on the bottom, you're able to see the two bars that they're actually using to push out. And we'll look at that in a little bit more detail in just a second. So they're using that to advance the mandible. This is somebody that slowly had their mandible advanced, and you can see over time how they've almost got a normal mandible by the time it's done. This is the posterior placement of it. So all they do is just drive this pin through here and it corrects that micrognathia. Here's another view of as they're actually distracting that jaw. Left lip on the left, cleft palate on the right. These are some of the most common things that we see in patients. You can see that the patient on the right has had his cleft lip repaired. You're not able to visualize the cleft palate. So a little bit more common, 1 in 600 births, more common in males versus females. We tend to see it's more common in those of Asian or Latin American descent and least common in African Americans. There's a wide variety of causes, environmental, genetics, and it's also commonly associated with about 400 other syndromes. It's able to be detected in the first trimester of pregnancy via ultrasound. This is just an example of what it would look like if you're able to see it internally. So on the right side there, you're able to visualize that palette. The middle picture, you have just a little bit more abbreviated palette. And then the last picture, it's almost entirely corrected. So patients with cleft lips generally repaired at about 2 or 3 months, whereas cleft palate is done generally at a little bit later in life. If you have patients with cleft palate, a lot of times they're going to have it revised at about 10 years of age. And this is just an example of a patient with a cleft palate. Not really anything to see externally. On the right side, though, you can see that they've got a cleft lip and a cleft palate, so continuing on up into the nasal passages. So things to think about as far as surgical repair goes. Um, do a thorough pre-op assessment because, as I mentioned, there's about 400 other abnormalities and syndromes associated with these patients. The difficulty airway incidence is about 3 to 23%, and it's generally more difficult in bilateral cases versus unilateral clefts. Micrognathia alone is a predictor of difficult airway, but it tends to decrease with age. Other things to be cautious about: microtia, hemifacial microsomia, or Treacher Collins. Most of these are non bloody procedures, so you don't generally have to transfuse them. From an anesthesia standpoint, you're usually able to accomplish a mass conduction without any sort of problems. Cricoid pressure may be useful as you kind of manipulate the laryngeal structures, utilizing direct laryngoscopy, video laryngoscopy, fiber optic intubation. All of those are often okay. As far as an actual endotracheal tube, we will commonly use an oral ray, and it's usually secured midline to the chin, so it's going down across the chin. This is just an example looking up into the palate. Sometimes there's some recommendations to use a Miller blade and kind of doing a paraglossal approach to avoid the cleft. As you can imagine, putting that into the cleft is probably going to cause a little bit of tissue trauma and hemorrhage, so you may consider avoiding that. These are some examples of common multimodal inductions for these patients. There's quite a bit of regional variety, just like we talked about the other day with scoliosis. So know what the local practice is. Other things you may see utilized here in addition to the multimodal is local analgesia by the surgeon. Even though I'm pretty comfortable with most nerve blocks, I don't do a whole lot of stuff inside the skull outside of like trigeminal neuralgia. Post-procedure, they commonly will place nasal trumpets for the patients and keep those in place for some extended period post-operatively. They also usually suture those in place so it's not a problem for you. If you're going to extubate the patient, it's usually done in the room and the patient's brought to be fully awake, or they may go straight to PICU. Post-procedure, due to their existing pathology as well as surgical edema, there's an increased risk for airway obstruction. So be very cautious with these patients. That's why we make sure we wake them up all the way. Something else you have to be careful of, just because you are leaving those nasal trumpets in place, they tend to not appreciate them very much. So you'll probably have to restrain the patient if they are extubated or put some sort of mitten or something on there. Next thing we're going to talk about is Down syndrome. It's the most common chromosomal abnormality we see, about 1 in 800 live births. Um, Primarily associated with trisomy 21, but you can see that there are some other mosaicisms that can occur. The classic physical findings: short stature, epicanthal folds, a short neck, and small or low set ears. Other things that are less common to see, or less easy to see externally: gastrointestinal problems, including duodenal atresia. About half these patients will have some sort of congenital heart defects, so be very cautious with that. And then on top of that, you tend to have poor tone as well as hypothyroidism. So those can be kind of conflicting structures that you may not be familiar with or kind of recognize just looking externally. So this is kind of an example of a classic patient with Downs: short neck, microglossia, and then mandibular hypoplasia. This bottom one, though, is the one that really troubles us with patients with Downs, and it's also one that is most commonly picked up on boards. They're at increased risk of AI instability and ligamentous instability, so you have to be very cautious while you're instrumenting their airway. Other things that can be problematic with these patients: subglottic stenosis. Because of their associated syndromes, they oftentimes require multiple anesthetics very early on in life, which predisposes them to subglottic stenosis. Because of that large tongue, they're at an increased risk of upper airway obstruction. Because of both those, you may have an increased incidence of post-extubation stridor. So be very cautious with these patients. Again, I would consider waking them up in the operating room and making sure they're fully awake. Other kind of weird fascinomas you'll see, they tend to have either small or abnormal radial arteries. So we will commonly use other access points if we are putting in arterial lines, usually down in the dorsalis pedis. Um, you may also see an increased incidence of bradycardia under anesthesia. If you've never seen actual subglottic stenosis, this is what you're going to run into. It's kind of deceiving to us because oftentimes we think if I can get a tube in the trachea, I'm fine. But what you'll see here is that the tracheal aperture is perfectly fine, but below that, because of that stenosis, you're having a hard time putting an endotracheal tube in. So this is one of the big reasons we keep smaller endotracheal tubes ready for pediatric patients, because you may not be able to advance the traditional size ET tube you're planning on. This is just an example of what you see with AI instability. So just be very cautious with these patients as far as manipulation of their neck, because it's very easy to put pressure on the spinal cord itself. So things to think about for these patients as far as the anesthetic approach. We talk about being careful with their airways because they are at increased risk of airway obstruction. We also talked about subglottic stenosis. Things to consider: get a good neuro exam on these patients, but also consider getting plain films or going back to find existing CTs, MRIs, what have you, to see what their C-spine looks like. As I mentioned, they are a little bit more prone to bradycardia. I will usually go ahead and pre-medicate these patients with down or with glycopyrrolate. Atropine's okay to have on hand, but usually I go ahead with glycopyrrolate. It's a little bit kinder and gentler. In a perfect world, you go ahead and give that before they become bradycardic. And that's what I've got. Have a good day.